continuing the series on esophageal pathologies, patient with dysphagia. Now, the cause of dysphagia can also be due to conditions like the presence of diverticula. Diverticulae of the esophagus are small, pouch-like sacs that form in the walls of the esophagus. Now, these sacs can collect food and cause symptoms like difficulty in swallowing, odonophagia, and even cause infections due to stasis. As we already talked about in the previous video, esophagus has 4 layers. The innermost layer is the mucosa, which is again divided into inner lamina propria and muscularis mucosa. The second one is the submucosal layer, and the third, thicker one depicted over here is the muscularis propria, and the last coat is the adventitia. And as depicted in this image, if there is protrusion of only the inner 2 layers, that is the mucosa and submucosa, through the muscular layer, then it is considered as a pseudo-diverticulum. If there is outpouching of all the 4 layers, then it is considered as a true diverticulum. Now, talking about diverticulae occurring in the upper esophagus, there are of 2 types, the Zenker's diverticulum and the Killian's diverticulum. Now, talking about the Zenker's diverticulum, it is nothing but a pulsion pseudo-diverticulum. The word pulsion indicates that it is occurring due to raised intraluminal pressure. It is a pseudo-diverticulum. It results from herniation of mucosa and submucosa through the Killian's triangle. They are called as a Killian's dehiscence, which is a triangular area which is located between the 2 muscles, which is the cricopharyngeus and thyropharyngeus parts of the inferior constrictor muscle, inferior pharyngeal constrictor. Now, this phenomenon may lead to creation of a sac, and which usually has a narrow neck and that can trap liquid as well as food, and the distended sac can even sometimes compress the cervical part of the esophagus anterior. Now, in this frontal chest radiograph, we see a pharyngeal pouch over here which shows an air fluid level in the superior mediastinum. Now, in this modified barium swallow study, we see an outpouching which is arising from the posterior wall of the esophagus over here, which shows retention of contrast even in the subsequent spots, which indicates that it is a diverticulum, and based on the location, it is compatible with Zenker's diverticulum. We can also see that there is luminal narrowing of the esophagus due to the mass effect by the pouch. Now, in this contrast enhanced sagittal section of the CT head and neck, we see a pharyngeal pouch arising from the midline posterior wall with motile layer foci, likely due to retained food and water. Now, talking about the second upper esophageal diverticulum, the Killian-Jamieson diverticulum. Now, it is also a false as well as pulsion diverticulum. It is, therefore, obviously, there is outpouching of mucosa and submucosa through a muscular defect. Now, they are located just below the cricopharyngeus muscle. In this diagram, if you remember, a Zenker's diverticulum was present over here between thyropharyngeus and cricopharyngeus, whereas Killian-Jamieson is present beneath the cricopharyngeus muscle. High intraluminal pressure due to functional esophageal obstruction may be the cause of herniation, and through this potential weakened site. Now, in this barium swallow image, we see a large lateral Killian-Jamieson diverticulum, which also shows retention of contrast. And here in the CECT coronal chest sections of the head and neck region, we see a left lateral outpouching from the cervical esophagus, which shows retained food content, which was a Killian-Jamieson's diverticle. Now, here is a table outlining the differences between Zenker's diverticulum and Killian-Jamieson's diverticulum. You can pause and take a screenshot. Now, talking about the middle esophageal diverticula, they are mainly due to traction or pulsion. Now, the traction diverticula, it mainly occurs due to secondary to pulling forces. These pulling forces usually from the outer aspect of the esophagus. It can be due to lymph nodes, like as in case of TB, which can cause caseous necrosis and cause fibrosis and cause pulling of the layers of the esophagus out. And in traction diverticulum, there all the 4 layers are usually herniated. Now, in pulsion diverticulum, this occurs secondary to raised intraluminal pressure, like in the Zenker's diverticulum, as well as Killian's. Now, talking about the lower esophageal diverticulae, the important one is the epiphrenic diverticulum. These are also pulsion diverticulum occurring off the distal esophagus, arising just above the gastroesophageal junction. More frequently, it occurs on the right side, posterolaterally. Now, these are considered to be pulsion type of diverticulum thought to arise due to increased intraluminal pressure. Therefore, this has a strong association with the esophageal dysmotility. Now, the diverticulum forms as a submucosa and mucosa herniate focally through the muscularis propria. Now, in this barium swallow study, there is an esophageal outpouching which is seen just above the diaphragm, and it is clearly separate from the rugal folds of the stomach. Yeah. So there's another entity called as intramural diverticulosis. These are nothing but there is nothing but presence of multiple small diverticulae within the esophageal wall, not protruding outside, outward like traditional diverticula. Now, typically it involves the mid to distal esophagus seen in elderly males who complain of progressive slow dysphagia. Tiny flask-like outpouchings are seen. Now, since it can be due to conditions like stricture, reflux, esophagitis, and candidiasis. So, treatment for it is to mainly treat the underlying cause. Now, here is a pictorial representative image of the same. We can see numerous tiny flask-shaped outpouchings. Now, in the barium swallow shown on the right side, we see multiple flask-like outpouchings which appear as if they are floating outside the esophagus. And these are compatible with esophageal pseudodiverticulosis. Now, we have another condition called as esophageal rings. Now, esophageal rings refers to various anatomical structures. They can even be pathological condition. Obviously, as the term implies, it is a ring. It compresses. It constricts the esophageal lumen. Now, normally there are three rings, important physiological wala. These include the A ring, B ring, and C ring. As depicted in the image on the left hand side, A ring is a muscular ring. Since it is a muscular ring, it changes its position with peristalsis. B ring, which is present beneath the A ring, is mucosal ring, which is constant. And this, if the mucosal ring tightens too much and it becomes symptomatic, this is what we call it as Schatzki's ring. And the C ring is nothing but the indentation. C ring is a diaphragm indentation. And now the area of the esophagus, which is present between the A ring and the B ring, is called as the vestibule of the esophagus, also called as the phrenic ampulla. The same thing is depicted over here. This narrowing is the A ring, and the one below it is the B ring, and this small dilatation of the esophagus is the phrenic ampulla, or also called the vestibule. Now, esophageal webs are also one of the important causes in which patient can present with dysphagia. These basically refer to esophageal constrictions which is mainly caused by thin mucosal membrane projecting into the lumen. More commonly, they occur in the cervical esophagus near the cricopharyngeus muscle, much more than in the thoracic esophagus. And what is important about them is that they typically arise from the anterior wall, never from the posterior wall. Very rarely, they can also be circumferential, and occasionally multiple webs can also be seen. And esophageal webs are also associated with conditions like Plummer-Vinson syndrome and graft versus host disease. Now, in this barium swallow image, we see a shelf-like defect in the anterior aspect of the upper cervical esophagus, which is causing a minimal upstream distension of the hypopharynx. And beneath that, on the posterior wall, we also see smooth posterior indentation, which is likely due to the cricopharyngeal bar, which is also at the level of the cricopharyngeus muscle. Now, in this barium swallow, we see the so-called jet phenomena, which is classically associated with esophageal webs. Now, here we see a tight upper esophageal stenosis, which is causing proximal dilatation, hold up of the contrast, with jet-like contrast passage through the stoma, which is referred to as the jet phenomena. Now, another condition which can cause dysphagia is the esophageal duplication cyst. Now, in general, enteric duplication cyst is a broad term, and it includes number of congenital cystic lesions that can arise anywhere along the GI tract. Now, depending upon the location, we divide it into foregut, midgut, and hindgut cysts. Now, esophageal Duplication cyst is obviously a foregut duplication cyst. These majority of the cases are unilocular with mucin within, and the wall contains one or two smooth muscle layers, and the inner epithelial lining of this duplication cyst is also highly variable. And the cyst contains mucin and detached ciliary tufts. Sometimes it can also contain heterotopic gastric or pancreatic tissue, which can also lead to ulceration. Now, in this frontal chest radiograph, there is a mass in the left upper zone of the lung, which shows obtuse margins with the mediastinum and is crossing the clavicle and entering into the neck. So, it is suggestive of a negative cervicothoracic sign. All these indicate that it is likely a posterior mediastinal mass. Now, on barium swallow, the cyst may cause extrinsic compression of the esophagus as well. In the CCT chest coronal section, we see a large fluid density cystic lesion in the left of the superior mediastinum, and it is abutting the esophagus as well. Fat planes are also not clearly visualized. Anyway, the lesion is also abutting the aortic arch inferiorly. However, it is important for us to differentiate between bronchogenic cysts and esophageal duplication cysts because they somewhat occur in the similar location. So here is a table differentiating between them. Now, important thing we have to consider between bronchogenic cyst and esophageal duplication cyst is the location. Bronchogenic cyst classically occurs in the pericardial location, whereas esophageal duplication cyst is always closely attached to the esophagus, abutting it. And the esophageal duplication cyst appears hypodense on CT, whereas bronchogenic cyst can sometimes appear hyperdense on NCCT images. And esophageal duplication cyst has no cartilage, and obviously, since it's a GI tract, it shows gut signature on ultrasound. Whereas bronchogenic cyst, which appears hyperdense on NCCT images, shows presence of cartilage within, which is unique to bronchogenic cyst and not seen in esophageal duplication cyst. Now, talking about another important and common cause of dysphagia, the corrosive esophagitis. Now, corrosive esophagitis is a form of esophagitis. Usually, it occurs from accidental or suicidal ingestion of substances. Now, since esophageal secretions are alkaline in nature, it neutralizes the acid ingested, and usually stomach is affected more in these cases. Whereas in ingestion of alkaline substances, esophagus is affected more. Now, the esophageal damage depends on many things. It depends upon the concentration, the type, the quantity of ingestion, the chemical composition of it, and the time of contact between the ingested substance and the esophagus. It usually affects the middle and lower third of the esophagus much more than the other parts. Now, here is a table differentiate between the acid ingestion and the alkali ingestion. Acidic ingestion causes coagulative necrosis, which is localized and superficial. Whereas alkali ingestion causes liquefactive necrosis, which is deep and causes much more severe damage. And in acid ingestion, what happens is that there is fibrosis occurring quickly. Therefore, the spread of the damage is less. Whereas it occurs late in alkali ingestion, therefore the spread of the damage is more. And one more thing associated with alkali ingestion is that initially both cause pain, but in alkali ingestion it is followed by numbness, which indicates that there is nerve damage. Now, talking about the stages, it consists of 3 stages: acute, subacute, and chronic. Now, acute, which is from less than 10 days of ingestion, it is characterized by acute necrosis with mucosal blurring. Whereas in subacute stages, which is between 10 to 20 days, is classically seen with ulceration. Whereas in chronic stage, there is fibrosis and later subsequently stricture formation. So when there is stricture, we have to know the differences between malignant stricture and benign stricture. So in this contrast swallow study, water soluble contrast medium is preferred in all the acute stages especially. So here in this image, in this contrast study, we see both malignant stricture and benign stricture. The upper one is a malignant and the lower one is a benign stricture. The malignant stricture, as depicted, these are usually short segment. These are completely asymmetrical, which has an eccentric lumen and shows shouldering. Whereas a benign stricture present over here, these usually are long segment, majority of the case, not always, shows progressive smooth tapering with a central lumen.